decision-making. We will proceed through 5 structured sections that cover the complete clinical workflow. We'll begin with the indications for the exam, then transition to the technical aspects of system preparation and imaging. From there, we'll focus on the correct interpretation of our findings and, most critically, how those findings directly inform and modify our anesthetic management.
So, Section 1. Let's first establish which patients require this assessment. A carotid ultrasound is not indicated for every patient, so a clear understanding of the specific clinical indications is the essential starting point for applying this protocol.
According to the PSMC guideline, indications are stratified by priority. It is mandatory to perform this scan for any patient with a history of CVA or TIA within the preceding 5 years, or for a patient presenting with a symptomatic carotid bruit. It's then recommended for individuals with known stenosis who are scheduled for major vascular or cardiac surgery. And finally, we consider the exam for asymptomatic patients who have a carotid bruit in the context of significant cardiovascular risk factors. All right, once the patient has been appropriately selected, the acquisition of a high-quality diagnostic scan is entirely dependent on meticulous preparation. This next section covers the essential technical prerequisites for both the machine and the patient. For standardization and reproducibility, we follow a systematic machine preparation checklist. First, power on the system. Select the high-frequency 9L linear array probe. Then choose the vascular application, followed by the specific carotid preset. Set your initial depth to between 4 and 5 centimeters. Place the focal zone at the level of the vessel, and then optimize the gain until the vessel lumen is completely anechoic. Lastly, ensure the correct patient is registered in the system. Probe selection is a critical variable. While very high-frequency probes offer superior resolution for superficial structures, the 3 to 9 MHz 9L probe is our standard. It provides the optimal balance of image resolution and penetration needed for the majority of adult carotid examinations, which are typically performed at depths of 2 to 5 centimeters.
Correct patient positioning is fundamental for obtaining adequate acoustic nundos. The patient should be supine, with their head turned 30 to 45 degrees away from the side being scanned, and the neck in a position of slight extension. It's important to add a critical safety note here. Always exercise caution and avoid any hyperextension or excessive rotation in patients who have known or suspected cervical spine instability.
We now arrive at the core of the examination itself. This section will detail the systematic, 3-phase scanning protocol that should be utilized for every patient to ensure a comprehensive and reproducible study is obtained.
One of the first and most crucial skills to master is the accurate differentiation of the internal and external carotid arteries. The ICA is typically larger, located posterolaterally, has no cervical branches, and exhibits a low-resistance waveform as it's feeding the brain. In contrast, the ECA is smaller, anteromedial, has visible branches, and a high-resistance waveform. The definitive maneuver is the temporal tap. Gently tapping the superficial temporal artery will produce distinct oscillations in the ECA spectral waveform, while the ICA's waveform will remain unchanged.
The examination begins with B mode, or 2D imaging, which provides the essential anatomical foundation. First, identify the common carotid artery in a transverse view. Survey the vessel superiorly, all the way through the bifurcation. Then, rotate the probe 90 degrees to obtain a longitudinal view, optimizing your image to clearly delineate both the near and far walls. Any evidence of atherosclerotic plaque must be documented during this phase.
Characterizing plaque morphology is absolutely critical for risk assessment. Echolucent or dark-appearing plaque is often lipid-rich and unstable, carrying the highest embolic risk. Calcified plaque is generally more stable, but creates acoustic shadowing that can obscure the lumen. The most dangerous finding, however, is an ulcerated plaque. This indicates a very high immediate risk of an embolic event, regardless of the measured degree of stenosis.
The second phase is color flow Doppler. You'll activate the color mode and set the pulse repetition frequency, or PRF, to approximately 50 to 70 centimeters per second. Steer the color box to maintain an appropriate angle of inclination and survey the entire length of the vessel. You're looking for areas of color aliasing, this mosaic pattern, which indicates a high-velocity jet and strongly suggests a significant stenosis. This is also the phase where you can visually confirm the ECA identity using the temporal tap.
Now for phase 3, our quantitative analysis, using pulsed wave Doppler. After activating the PW mode, the first and most critical step is to align the Doppler angle correction cursor parallel to the vessel wall, ensuring the angle is 60 degrees or less.
We then measure the peak systolic velocity in the distal common carotid artery. This is followed by measuring both the PSV and the end diastolic velocity at the point of maximal stenosis within the internal carotid artery. From these values, we will calculate our final ICA to CCA ratio. This point requires special emphasis. The angle of insonation must be maintained at 60 degrees or less. Angles greater than 60 degrees introduce a significant cosine error, which leads to a clinically relevant overestimation of blood flow velocity. A measurement obtained at an angle greater than 60 degrees is invalid and must never be accepted. So, with all of our data acquired, we can now proceed to the analysis phase. In this section, we will integrate our B-mode findings and our Doppler velocity data to formally grade the degree of stenosis and understand its hemodynamic significance. An important marker of subclinical atherosclerosis is the intima media thickness, or IMT. This measurement is performed on the far wall of the common carotid artery, approximately 1 centimeter proximal to the bifurcation. You need to optimize the image to visualize a distinct double-line pattern and then measure from the lumen-intima interface to the media adventitia interface. The measured IMT value has direct anesthetic implications. Specifically, a value greater than 0.9 millimeters is considered clear evidence of a significant atherosclerotic burden. For the anesthesiologist, this finding should be a flag that indicates a need for much stricter intraoperative blood pressure management and potentially enhanced neurologic monitoring. This table is the cornerstone of our stenosis grading, employing the validated NASCET velocity criteria. A moderate, 50 to 69% stenosis is defined by an ICA peak systolic velocity between 125 and 230 centimeters per second. But the critical threshold we must identify is for severe stenosis, that is 70% or greater. This is defined by an ICA PSV that exceeds 230 centimeters per second, an end diastolic velocity over 100, and an ICA to CCA ratio greater than 4.0. The morphology of the spectral Doppler waveform provides additional crucial diagnostic information. A normal ICA exhibits a low-resistance pattern with continuous forward flow throughout diastole. A significant stenosis will produce spectral broadening due to turbulent flow. And importantly, distal to a severe, flow-limiting lesion, you may observe a tardus parvis waveform, which presents as a dampened, slow-rising systolic peak. And finally, we'll synthesize this information. This last section is dedicated to translating our ultrasound diagnoses into concrete, actionable changes to the perioperative anesthetic plan to maximize patient safety. This framework provides a direct link between stenosis severity and our subsequent actions. For a moderate 50 to 69% stenosis, a vascular surgery consultation is warranted, and we must maintain a higher intraoperative MAP target. For a severe stenosis of 70 to 99%, a vascular surgery referral becomes mandatory. Elective surgeries should be postponed, and intraoperative mean arterial pressures must be meticulously maintained at 85 to 90 millimeters of mercury or higher, always utilizing invasive arterial monitoring.
This statement from the guideline truly encapsulates the most critical principle. The single most important anesthetic consideration is the strict avoidance of hypotension. The pathophysiology is clear, cerebral autoregulation is impaired distal to a high-grade lesion, which makes cerebral perfusion entirely dependent on systemic blood pressure. To provide a clear, clinically applicable target, for any patient identified with a 70 to 99% stenosis, your minimum mean arterial pressure target during the anesthesis is 85 millimeters of mercury. This should be considered a critical safety benchmark. Let's conclude with a clinical scenario to solidify this protocol. You identify a patient with an asymptomatic 80% left ICA stenosis who is scheduled for major abdominal surgery. Based on the protocol we've just reviewed, what is your immediate next step? The answer should be clear. You must postpone the elective surgery and initiate a mandatory urgent referral to vascular surgery for assessment for revascularization.